rapid detox is what you've done, inadvertently. But so it's not used very often in most emergency rooms. Sedative hypnotic withdrawal, pathophysiology. Look at that. No conclusive data explain how sedatives function. They don't really know. They have lots of hypotheses. But once again, the thinking here is that there is some down regulation. There's actually some subtypes, benzodiazepine subtypes. This is some benzodiazepine 1 and benzodiazepine 2 type subtypes of GABA receptors. And somehow they lose their sensitivity or they downregulate with chronic use, so that when you take away the benzodiazepine, everything is just the opposite hyperactivity. Clinically significant syndrome of withdrawal following cessation of therapeutic doses. This is interesting too. 4 to 6 months. In other words, therapeutic doses, I mean the person who's been prescribed Ativan for anxiety, and they're taking it appropriately. They're taking their Ativan 0.5 milligram 3 times a day. 4 to 6 months of taking it that way, probably going to have withdrawal syndrome. 2 to 3 months following cessation from high dose. This is what the literature says, but the anecdotal literature says maybe as much as 1 month. Okay, so and there's lots of cases of that where patients have been taking, even therapeutic doses of benzodiazepines in, 5 weeks, 4 weeks, 5 weeks, and they have a withdrawal syndrome. Okay, so this is a general guideline, but it may happen sooner. Once again, like I said at the beginning, everybody's unique and everybody's different. So, and once again, I always err on the side of being cautious. So a patient comes in and tells me, yeah, I've been taking Xanax 1 milligram 3 times a day for 5 weeks. I'm probably going to say, yeah, you're going to have withdrawal. You may have withdrawal. I'm going to treat them like I anticipate them to have withdrawal. Sometimes these are the patients that we get those, that I always give you my silly orders, say, please monitor. I know for sure. We're going to watch and make sure. Onset of symptoms is variable. Typically 1 to 3 days, and the symptoms tend to peak at 5 to 6 days. That's a little dependent on the type of benzodiazepines too. Like the long-acting benzodiazepines, seems like they peak a little bit longer down the road. Maybe it's 7 or 8 days that they're having their peak symptoms. That's quite a bit of time. I said earlier, remember I said there's some controversy because there are some people that believe that sedative hypnotic or benzodiazepine in general may cause a protracted withdrawal symptoms, and the literature says 1 month to 1 year. It's actually a very difficult thing to measure because, as I said earlier, a lot of the symptoms are subjective. And if you look at a patient, maybe I'm getting ahead of myself. We'll talk about it in a minute. Okay, so sedative hypnotic withdrawal symptoms, there's actually 4 etiologies here. Recurrence. You know what I mean by the recurrence is, why does a person generally take a benzodiazepine to begin with? Anxiety. Usually because they have anxiety. Okay, so recurrence just means that you've got a reoccurrence of those symptoms that they had before they start taking their benzodiazepine. And maybe that's why they're complaining of symptoms or anxiety. A rebound is that so neuroadaptive kind of thing that we talked about earlier. You stop taking it, your brain's used to it, and you rebound. Pseudo withdrawal, kind of ignore that. This is the person who anticipates having symptoms, and therefore they have symptoms, and then it's usually combined with some mild symptoms. And they call it pseudo withdrawal, and there are some people that would like to make a case for protracted or long-term withdrawal actually being pseudo withdrawal and true withdrawal. Now, the reason why I said it's controversial is because there's a couple of things that happens in a person who's been taking benzodiazepines for a long time. First of all, they've really never treated what they were trying to take the medication for in the first place. That whatever it was, their anxiety and stuff. So you take away the medication, they're going to have lots of symptoms, the anxieties or recurrence. And that can look like withdrawal. Okay? There's a true process where some people believe that it may take your brain a long time to get back to baseline or where it was before you start taking the benzodiazepine. And some people it might happen in months, some people it may take 12 months. So there could be some symptoms there. Maybe they down-regulate and their brain's just not going to bounce into shape again for a while. And then if you think about the person who's constantly eating a benzodiazepine where they have an anxiety, they've really stopped developing coping strategies. I mean, we deal with anxiety every day. I had anxiety about coming here and doing this lecture, right? And we have ways of dealing with that anxiety. Well, the person who swallows a pill for, say, 10 months, that's 10 months where they've actually not been depending on those coping strategies normally would either develop new coping strategies or the ones that they had before. Okay, so it's complicated, and even the people that subscribe to this, there's a couple. I think I have a very good article there too, if anybody's interested on a woman. She's an English physician who is real popular amongst the concept of protracted withdrawal. Even she believes that it's multifactorial, that it's not just physiologic. I didn't want to. Actually, I ran out of time, so I didn't put all the symptoms up there, but I put it on your handout. I think it's in the back there attached. We talked about the symptoms, benzodiazepine withdrawal, and once again, there's a multitude of symptoms: adrenergic, anxiety, restlessness, agitation, nausea, vomiting, blah blah. All the things very similar to alcohol withdrawal. Here's an interesting thing too: is that alcohol withdrawal, you do tend to see a lot of elevation in blood pressure and pulse. Now, just because it's not on the form, because they haven't been able to show that it's valid or reliable in terms of over and over again, we do know that patients, when they're progressing, tend to have hypertension and tachycardia. That's not seen anywhere near as often in benzodiazepine withdrawal. In other words, you can't really depend on those vital signs for benzodiazepine withdrawal. Now, they may, if it gets bad enough, but not always. In fact, most cases not the case. So, musculoskeletal, you see them, tremor, weakness, fasciculation, spasm, cramping. These patients complain of a lot of symptoms that sometimes they can't even pin down. They don't feel good. Neuropsychiatric, hypersensitivity, light sound, lightheadedness, dizziness, depression, depersonalization, and then others, lethargy, fatigue, loss of drive, blah, blah, blah. So anyway, just about every symptom that you possibly could have, you can have with sedative hypnotic withdrawal. These patients are usually uncomfortable, and they usually let you know. Sedative hypnotic withdrawal management. There's my error. Should be tapering or substitution. Usually, tapering basically means usually tapering a dose is reserved for a patient who's using a therapeutic dose of benzodiazepines. They come in on Klonopin 1 milligram 3 times a day. They're not abusing it. They haven't been overusing it. But usually that's the person that you would consider using tapering. In other words, so you're on Klonopin 3 milligrams. We'll make it, 2.75 for a couple of days. And usually tapering requires a longer period of time, too. That's why it's kind of popular in outpatient. And some people would say that patients who have chronic, habitual users of benzodiazepines, therapeutic dose for a long period of time, the best way to detox them is to slow, gradual taper, maybe as much as 3 to 4 months on an outpatient basis. Okay? Now, sometimes that's not a necessity because you don't really have the patient in your hospital where you can watch them and see how they respond. Okay, so you can go back to it. But usually it's reserved for outpatient settings, therapeutic dose dependence, and single benzodiazepine use. Okay, in other words, they got one benzo. Substitution is finding a cross-tolerant drug. In other words, has the same effect. Long-acting benzodiazepines or phenobarbital are the drugs of choice, of course. And once again, I think we got a handout there. So there's a handout the next page on elimination half-lives. Just how fast things act and how long they stay on board. Long-acting medications, they make it a little bit smoother. They don't get that sort of euphoric disinhibition that occurs with the fast-acting like Xanax, and tend to be more effective. So, classically, what you're looking at is using Librium, Diazepam, although we don't use Valium a lot because it is very fast-acting, and clonazepam or phenobarbital. And usually, most of the phenobarbital I prescribe is in the patient who is polypharmacy, using lots of benzodiazepines, and you can't even get them down to one, that they use as their drug of choice, or they're using benzodiazepines and alcohol. So let's move on to opioid intoxication. Symptoms of opioid intoxication. This is not the patient who's withdrawing. This is the patient who just used. Mild to moderate symptoms are sedation, euphoria, and analgesia. They don't feel pain. Actually, they still feel pain. They just don't register it. Severe respiratory depression and death. So this is unlike the benzodiazepines, where it's rare to have a toxic effect of fatal. Not the case with acute opioid intoxication. Pathophysiology. there are several opioid receptor sites, mu, kappa, delta types, and when you talk about treatment, we'll talk about it a little bit later, the differences in terms of those sites and what type of medication you use. But the mu receptor sites tend to be the ones responsible for sedation and respiratory depression. Okay, so the interesting thing is a patient can take they can take an opioid that they're abusing that perhaps works here, and they develop tolerance, so they keep increasing the dose, so they get that euphoric effect on this kappa sites, makes them feel good, but they really haven't developed tolerance to the binding at that mu site. In other words, they're increasing the dose to try to get the euphoric effect, and they get toxic before they know it, and they have respiratory depression and die. Okay, and opioids are profoundly, they have when I talked earlier about kindling, there's another process that occurs with opioids, is that you lose your tolerance fairly quickly in opioid dependence. So these are the patients that have been using high doses of opioids. They get detoxed, they go through treatment, they relapse, and they go back to the dose they were on before, and we hear about it. They're dead. And sometimes I'm wondering if maybe it's a good thing to educate these patients before they walk out the door. We don't like to say if you relapse. It feels like would you not like a male provider? We don't want to put but the idea is that if they do, there's a very real possibility that they've lost their older tolerance and that they could have an adverse effect such as death.
We do talk about that in the group.
Yeah. Okay. Good. Right. Yeah. We've had patients here, by the way.
We had one. Yeah.
Yeah. Not too long ago.
Yeah.
Right. Absolutely. So treatment for opioid intoxication. This is normally acute intoxication is an emergency room evaluation, treatment to ICU, supportive management, airway fluids, assess cardiac function, monitor for rhabdomyolysis. Because if this progresses, the renal kidney starts shutting down and so forth. Naloxone hydrochloride, pure opioid antagonists. This is Narcan, basically, to reverse effects of opioids. And Narcan is very effective. For those of you who worked in the emergency room, it's actually unbelievable how fast you can turn a patient around. And I'd say that some people say, well, you got a dose of Narcan, 2 milligrams or a milligram of Narcan, and he's still obtunded. They give another one, he's still obtunded. Well, that's when you start looking for something else, because Narcan will reverse opioid intoxication. There consider alternative causes of unresponsiveness, no response to naloxone or Narcan. Okay, so once again, the pathophysiology, it's kind of complicated. It's a little bit opposite. Remember I said earlier, like you think about benzodiazepines, they have an effect on GABA, and because they're always there, then you start down-regulating your production of GABA. Well, with opioids, it's a little bit different, because even though they bind at opioid receptor sites, it doesn't seem like the opioid receptor neural adaptation is what causes the symptoms of withdrawal. It seems like that actually has increased CNS noradrenergic, or like catecholamines, primarily a specific area in the brain called the locus ceruleus. They've done lots of studies about this. Patients look like when they're having opioid withdrawal, they look like someone who's stimulated, like noradrenergic kind of stimulated. One of the reasons why clonidine, which is alpha agonist, is helpful. So and they've done studies like where they can find norepinephrine metabolites. Norepinephrine being the adrenergic activating kind of neurotransmitter in the brain. So there are other things that are in process here. There probably is downregulation of natural opioids or endorphins. And there's some people who make a case that maybe the person who becomes opioid dependent already has some kind of depleted natural endorphin system, and that makes them prone to, everybody take Vicodin or something like that and say, hey, I felt like normal for the first time, like something wasn't quite right in the brain, so they kept taking it. Onset is related to the half-life. Usually onset pretty rapid with heroin, 4 to 6 hours. Methadone maybe up to 36 hours because of the long half-life before they start experiencing symptoms. So that's usually what an answer that why when was the last use is important. Because the person that just took 100 milligrams of methadone, they're probably not going to have opioid withdrawal till late tomorrow night. Now, not always the case. Might start a little bit earlier. But anyway, that's important when we talk about Subutex. Okay, so opioid withdrawal symptoms: vital sign, tachycardia, hypertension, fever, CNS, restlessness, irritability, insomnia, yawning. Man, they've got everything too. Pupillary dilation. When they're withdrawal, the pupils are big. Midriacid, like the belladonna kind of effect. When they're acutely intoxicated, they got pinpoint pupils. Right? Lacrimation, nose is running, their eyes are wandering, nose rhinorrhea, skin, piloerection, or they have goose flesh. That's one of the few positive, and actually, objective symptoms of alcohol withdrawal, you can see the tremor, you can see sweat coming off of them. One of the objective symptoms of opioid withdrawal is that you can actually see goosebumps on them, GI, nausea, vomiting, diarrhea, others muscle cramping, bone pain, tremor. And these patients tend to, I'm not trying to be negative, but patients that are in opioid withdrawal tend to have lots of complaints. First of all, they have lots of symptoms. And if you stop and think that they've been using this opioid, they've dulled the brain, so their brain's not as sensitive to emotional stimulus, but they've physically sort of dulled pain. And I'm almost thinking that maybe there's some kind of neural adaptation there too, where small discomfort seems like a lot of discomfort. You know what I mean? Because they don't really have the natural endorphins to deal with it. And maybe that's why they started using opioids in the first place. So combination of factors, but they tend to make a lot of noise and complain a lot. And I've never seen anybody die from opioid withdrawal, although people think they're going to die. And they'll tell you they're dying, right? Because I have that. Treatment, generally supportive, environment, nutrition, fluids. Once again, I get back to that. And I had a couple things in my mind when I was talking about this that I want to emphasize. Patients who are on detox, give them the benefit of the doubt. There's a natural part of us that ought to think, well, the patient's seeking medication, this is medication-seeking behavior and stuff. But they're only going to be on detox for a certain period of time. And we really want to make them as comfortable as possible, make their detox humane and as comfortable as possible, so they stay engaged and do the part that they need to do, which is the treatment. Right? If they don't, they feel miserable and they just up and leave, then it's defeated the whole purpose of coming to treatment, right?
Yeah. What about these people that live like we have somebody that lives on the other side of the United States and they're a heroin abuser and they call and they want to come into Cottonwood. What do you tell them to take so they don't go throw them in the plane? That's an ethical thing. Okay. I don't tell them to take it. Yeah. I
don't really care if they have withdrawal.
But,
Now there's some people that says that like something because you're not going to be fatal. You know what I mean? They're not going to have deleterious effects. There are some patients. I've never been in a situation where I had to tell a patient to drink before they get here. You know what I mean?
Yeah, I know.
But I know that has been said before. Usually where people are referred by healthcare professionals, don't change what you're doing. That's how you get back. So don't change what you're doing until you get there. That's why most of the patients bring it on the plane.
This guy took a bunch of Percocet, got on the plane and got on here.
Yeah, all right. Whatever. All right, so clonidine is alpha-2 agonist. It decreases norepinephrine release. Good for the autonomic mediated signs, but not for their subjective symptoms. The patients really they actually have some improvement in those autonomic systems, but subjectively they're still not feeling that good all the time. We've been looking for a long time for something effectively detox patients on. There's a lot of facilities that use methadone. There's some drawbacks to doing that because basically you're using an opioid and there's lots of side effects.
And it's addictive.
Yeah. So we're abstinence-based, something like that. There are some, Lafexidine, and I thought Jason was going to be here today, and I don't think that Lafexidine is FDA approved in the United States. It is being used in controlled studies in some places. It's been used in England. Lafexidine is basically very similar to clonidine. It's an alpha-2 agonist that decreases norepinephrine, but it doesn't have hypertensive effects. Doesn't tend to drop the blood pressure. And you guys all know from experience that sometimes because if you look at using clonidine, you really got to use doses of clonidine up to like 0.8 milligrams. And antihypertensive effect is 0.1 to 0.2. So sometimes you might, be able to get enough clonidine on them to help with their symptoms, but then they get the side effects of orthostatic hypotension and the sedation from their blood pressure being low. There's an interesting story about a patient I had one time as a nurse who, I came on evening shift and the patient said, well, the patient's blood pressure is like getting lower and lower, And I went in and took the patient's blood pressure, and I think it was like 80 over 60, and the next time I checked it was like 60 over, I couldn't get it, or something like that. I'm like, what's going on here, Couldn't figure out why his blood pressure was dropping lower and lower. Well, this guy had been in prison before, And he had been in prison where their idea of detox was they put a clonidine patch on you, gave you Motrin, and sent you off to your room, you know. So somehow in prison they figured out they could eat that clonidine patch, and they'd get this rapid absorption of clonidine, and it'd drop their blood pressure so low they just go out, and they just sleep through their detox, you know. So somehow I figured that out, and it wasn't until I told them that, you know, I think you might be dying. You know, we got to do something. We're going to have to send you off the thing. I said, what did you do? He said, oh, well, I've been eating my patch, you know. And then here's the funny thing is when he first had low blood pressure, somebody said, pull the patch off, you know. So the nurse pulled the patch off and threw it in the trash can. So I went back and looked at the trash can. There was only a little bit of the patch left. You know, he'd been taking it, biting a piece off, putting it back on. Anyway, there is something called rapid detox where we put patients to sleep and then they don't experience it. And we're not really doing it very often, and still done some places, you know. But then they sleep through their okay, so buprenorphine is an alternative. Subutex. We want to talk about Subutex, right?
Yes.
Okay. So let's talk about Subutex, okay? Or buprenorphine. Subutex, which is sublingual, or Suboxone. There's only one difference. By the way, these are only 2 formulations that are approved in the United States. And there's all kinds of special regulations about prescribing these medications. When this medication first came out, the idea was to use it like methadone for induction, then substitution, and then maintenance. Okay, and the idea was instead of having a person had to get involved in a methadone clinic and go to the methadone clinic and everything else, was that at family practice people could treat patients, basically do Suboxone maintenance, an alternative methadone maintenance program in the office. And they put up restrictions like said you can't manage more than 30 patients because they didn't want it to be money making for them and so forth. And in order to prescribe this, you have to have a special DEA qualifier. You have to take a course and then you have to get a DEA qualifier on your license, okay? Mid-level practitioners like myself, because when they wrote it up, they didn't write medical provider, they wrote physician. The law hasn't changed yet, so I can't get this qualifier. That's why you guys probably noticed that I always write it as a telephone order from Dr. Seymour or Dr. Moore when we put someone on Subutex, okay? But anyway, the only difference between Subutex and Suboxone is that Suboxone has naltrexone in it. Okay, and the reason they put it in Suboxone is because they're using Suboxone outpatient, and this is naltrexone is an opioid blocker. So conceivably, if you were to crush Subutex and inject it, you could get high. But you can't with the naltrexone in it. Okay, and the interesting thing is that naltrexone is absorbed very poorly in sublingual preparation. In other words, you get very little effect from the naltrexone if you take it under your tongue like you're supposed to. In other words, it doesn't really block the effects of the medication unless you inject it. Okay, so that's really the only big difference. And we tend to use Subutex here because we have patients in controlled fashion and we have no plan for putting them on maintenance because we're abstinence-based, right? So we use a simpler preparation with Subutex. So what is it? Partial agonist at mu receptors and antagonist at kappa receptors. Okay, so what this means is that it does, how do I say this? It does make you feel a little better. It does make you feel a little good. Maybe, God forbid the word, a little euphoric. Okay, but not much, because it's working most at this mu receptor site. Okay, and then it actually blocks this site right here, and the site, you know, this is the site where you have all the problems, you know, the person in their overdose and everything else like that. So you block this site, they really don't get the kind of buzz or hit they would if they were taking methadone or some other opioid. Okay. As a matter of fact, that's been one of the problems in using it in detox. You know, little euphoria and decreased sedation, so you don't get those side effects where the person's just run like methadone or LAM. Here's the important note: may precipitate withdrawal if started too early. That's, you know, there is enough because it is an agonist and an antagonist. It may bump off those opioids that are bound off. So you might make the person go into withdrawal, more rapid withdrawal, if you were to start it too soon. Okay? So generally, the idea is to, you know, because we think about the heroin, the half-life of heroin about 4. Actually, the half-life of heroin is really fast, like 30 minutes. But metabolite ways, heroin breaks down to metabolite that actually has about a 4-hour half-life. So generally, you're looking at patients probably having some withdrawal from using heroin 8 to 12 hours, and you're probably okay with starting the Subutex. OxyContin longer. 12 to 16 hours, and methadone 24 hours. And some people say as long as 36 hours before you start the medication. Because the idea is you don't want them to have a, you do the same thing if you gave this person, Narcan, give them rapid. There's a little risk for that with using the buprenorphine. Now, the question here is, why use buprenorphine? Why not use? Well, once again, it seems like the clonidine helps, but not a whole lot. And then we use a lot of other comfort medications, of course, the Robaxin for their muscle aches, ibuprofen for their bone pain, some benzodiazepine probably for agitation and irritability. Those are all comfort medications, basically. They're not really treating the opioid withdrawal. When the studies came out, when they were using that buprenorphine, some people started doing it, let's use this for withdrawal, let's use this for detox. With the plan not being get them up to a certain dose and then leave them on it, And it did, a lot of the studies were very promising. Patients tend to be less symptomatic, have less complaints, and so forth. So there was kind of a push for using buprenorphine and, for detox. And to be very honest with you, there's not a whole lot of controlled studies out there. There are some that are ongoing right now when you're looking at efficacy and so forth, and how many patients stay in treatment and so forth. But there's not a whole lot of studies out there. Induction period, 1 to 2 days, and taper over 5 to 7 days. This is sort of the plan we use here. And there is no recipe. You will not be able to type in and find a protocol that says this is how you do detox with buprenorphine. And you can say this study did it this way, and this study did it this way. And so we kind of put those as a conglomerate, and we do it a certain way here based on what we've seen in the standard of care, what other people are doing that seems to be effective. So that's usually why we start off with, giving the patient Subutex PRN for the first 24 hours or 2 days. So we know how much dose is required to get their symptoms under management. And then a taper after that, maybe by 1 milligram or by 2 milligrams every day. Generally here we stay between 8 and 12 milligrams because that's what a lot of the research showed was effective for treating treatments. And there are some studies that went as high as like 36 milligrams and some even higher. But there really wasn't good support for using the higher doses. In fact, some people say if 8 to 10 milligrams doesn't work, more doses aren't going to have any impact. Okay. But induction, get them on the medicine, find out how much it's going to take to treat their symptoms, and then taper over a 5 to 7 day period. Oh, look, 10 minutes to dissolve. Medical providers don't ever worry about that. But this means that really that patient should probably sit in the medical clinic under observation for 10 minutes. So they don't spit it out and give it to somebody else or something like that. This was an interesting, probably the most current. Bowling Green Brandywine is a big treatment facility that's fairly popular. They actually did some research on. They started using buprenorphine, and that particular facility, the majority of their detox protocols were methadone, and they did do some clonidine, but mostly methadone. And so they were looking for an alternative, and their research was very promising with using buprenorphine. But remember too, this was in comparison to using methadone. So they found less sedation, they detoxed faster, had fewer complaints, and fewer patients left. And then when they went back and they asked patients, what were your symptoms and stuff like that, they said that it was a smoother detox. Now, the interesting thing is there was an exception. Patients who had previous detox with methadone did not like buprenorphine. And when they really pinned them down to why, they would say they had more symptoms, but when they really said, well, what kind of symptoms, what do you mean? It really boiled down to that they weren't feeling high. They weren't getting that bump they got with the methadone. So therefore they thought it wasn't working as well. But in reality, they had a smoother detox. It just subjectively they didn't think they did. Okay? Now, as an antidote, one of the drawbacks to using buprenorphine, besides things like 10 minutes to watch them, you have to have a special DEA to prescribe it, is that, and this is something I've experienced here, I don't see a lot of talk about this in the literature, but it seems like it's difficult to get patients off that last dose. They do not want to give it up. Now there may be something physiologic there because, if you think about the brain, they're going through withdrawal, the brain's saying, where's our endorphins, where's the opioids? And they don't have any natural endorphins because they've been using opioids for a long period of time. And all of a sudden you give them an unnatural endorphin that actually binds at the same place. And even though it's not a real strong agonist, it still makes the brain think, okay, everything's all right. So hard to give up that last dose. And then I think there's some kind of placebo effect also. You know what I mean? That you just can't let go. You know, patients will come in and tell you, I got to at least have a half a milligram. And I can't even equate, half a milligram is so sub-therapeutic in terms of dosing. You almost get, well, it doesn't even come in that. It comes in 2 milligrams, a small dose. That's why you guys have to do the half, the quarter things like that. So, you know, that's one of the drawbacks to using it, is that the patients seem to have a difficult time of coming off. And then there's another side effect, and there's another drawback that we haven't really talked about, that sometimes patients get on it, they like it so much they want to go onto a maintenance program. We had 2 patients that happened to. So, okay, stimulant intoxication. I'm going to talk fast here. Pathophysiology. Cocaine blocks neurotransmitter presynaptic uptake pumps. Amphetamines tend to increase presynaptic release of catecholamines. Basically, they do a similar thing. You get hyperactivity in the brain when you take a stimulant. Symptoms form disinhibition, hypervigilance to compulsive stereotype behavior. In other words, they can just feel a little bit happy, euphoric, expansive, you know, flight of ideas and all that kind of stuff, all the way to the point of being, you know, picking at themselves, feeling paranoid, and having frank psychosis. Severe intoxication is very similar to the PCP intoxication, and patients can have higher levels of strength. They can be unpredictable, and they can be violent. You know, and if anybody ever makes that comment that stimulant or drugs won't make you do anything that you normally wouldn't do, they have not had any experience with amphetamines, especially crystal methamphetamine, because you will do things that you normally wouldn't have done. Symptoms: pupillary dilation, headache, bruxism, grinding of teeth, picking at their skin, pulmonary increased rate and depth, pulmonary edema is possible, cardiac pulses increased to 30 to 50%, blood pressure 15 to 20%, vasoconstriction, arrhythmia, myocardial infarction, cardiac shock. You know, it's a little bit different. The myocardial infarction that occurs in an acute stimulant intoxication tends to be vasospastic. The vessels have clamped down, and that's why I don't get blood flow. It's not because a clot is broke loose and gone through. That's why they tend to recover a lot faster too, because they usually don't have as much ischemia. Neurological tremor, hyperreflexia, muscle twitching, tics, seizures, and coma. Hyperthermia, you know, this is a very fatal. The brain goes haywire. Your temperature starts going up and up and up. And this is why sometimes you've heard me say when patients come in and they just use cocaine out in the parking lot, that I want to make sure you check their temperature too, because they can develop neuromalignant hyperthermia. And if they get neuromalignant hyperthermia, this can be fatal. I mean, in fact, often is. I mean, they get rhabdomyolysis, their kidneys shut down, and everything. Brain cooks, you know. Not a good thing. This is intoxication now, because we never think about detox from stimulants. What's probably more important is the intoxication. Treatment: basic life support, airway, and cardiac monitoring of patients that are very severe. Temperature greater than 102 needs aggressive management. Patients that are stimulant intoxicated, that just use high doses of stimulants, and their temperature is climbing up to 102, 103, they need to be in the ER. Because they need ice gastric lavage, they need ice baths, they need to get the temperature down, hypothermic leg, and so forth. Benzodiazepine versus neuroleptics. You know, patients can get psychotic. I mean, that happens quite a bit on stimulants, you know. And sometimes we don't know, this is somebody who's a pre-existing psychosis and the stimulant bumped them into it, or is it true stimulant-induced psychosis? And there is such a thing. So lots of people have used neuroleptics. I've never been a proponent, and I think the literature supports this, of using neuroleptics for that type of psychosis, because you increase the risk of that neuromalignant hypothermia and neuromalignant syndrome. So, avoid beta blockers. There are some people that believe that beta blockers may calm things down, but they actually can contribute to some of the cardiac manifestations of. In fact, there's some belief that they may increase your risk for a vasospastic myocardial infarction. Beta blockers. Pathophysiology, there's a dopamine deficiency hypothesis. This is kind of interesting because we're talking about stimulant withdrawal now that we never treat patients for, because we don't worry about it, because it doesn't, you know, there's no liability. But we know patients undergo the process, you know what I mean? They're not comfortable. They come off that stimulant. And unlike you think in your mind, the pathophysiology must be, well, they have adrenergic stimulation, they've got norepinephrine and dopamine. It's actually all the catecholamines, but it seems to principally be related to dopamine, you know. And patients don't feel good. They'll tell you they feel depressed, they got that drop, they're dysphoric and everything else. That's one of the reasons why for a while they were using, well, first they were using tricyclic antidepressant, Diazepam to treat it, and then there are too many side effects. But sometimes actually probably one of the few places where you could actually say that trazodone for sleep might be also helpful. because trazodone indirectly increases dopamine levels. So it might be a good indication for a patient who's, having a stimulant withdrawal. Depression, energy, no energy, anhedonia, cravings, increased appetite, hypersomnolence, increased REM. Sometimes these are the patients that sleep for three days, And, supportive treatment, short-acting benzodiazepines. This is for withdrawal now, short-acting benzodiazepines. Because you don't want the side effects to persist. Rest, nutrition, trazodone. It's okay, I think, for these kind of patients, that if they're going to have to crash for 2 days, let them crash. They can't really engage and do anything anyway when they're in that state, so benefit of the doubt. Okay, talk real fast about GHB withdrawal. Everybody knows what GHB is, gamma hydroxybutyric acid. This is an interesting drug that in the past we didn't think there was any withdrawal associated with it. It has both sedative-like properties and also sometimes even some hallucinogenic-like properties. But people compared it to rohypnol, and then there's some anabolic effects too. Some weightlifters have used it before in the past. And as a matter of fact, when this drug first came out, because it wasn't listed, wasn't listed as a narcotic because it wasn't around. And then finally DA said, oh, that's a narcotic, so they banned it, said, oh, it's a controlled substance, right? But then all these backstore chemists and organic chemists, they started making analogs of GHB. And they said GHB1 or GHBA and these analogs that really were legal. You could get them because, the legal hadn't caught up with them. They had similar effects. Sometimes they weren't as clean as the GHB, but anyway. It seems that there is a withdrawal process associated with GHB, and I have a real interesting article that it's not real new. It's like from 1999 that I downloaded if anybody wants to look at it, because I've read it before in the past. But these patients can have profound withdrawal that looks like both alcohol and benzodiazepine withdrawal. But it seems to only be in the person who's doing this kind of thing, using GHB nonstop. You don't see it very often, a person using GHB every day, or once or twice a week or something. This person using it around the clock. And in fact, all the anecdotal cases of severe GHB withdrawal have been in patients that have been doing this kind of thing, just using it nonstop around the clock. Drug has a very short half-life. That may be one of the reasons. It's kind of hard to think about having withdrawal from this drug that was out of your system like in 30 minutes. But symptoms start rapidly, 1 to 6 hours after last dose. Withdrawal shares features of both alcohol and benzodiazepine withdrawal. Delirium may evolve much faster, but slightly less severe. These patients are treated almost the same. Benzodiazepine is still the drug of choice. The only difference is the patient may require profound doses of benzodiazepine. As a matter of fact, in the literature, there's been cases of 2,000 milligrams, I think 2,000 milligrams of Valium. Just unbelievable doses. I know whoever did that. Because I don't think I've ever take 200 times the maximum dose of a medicine. But they seem to require a lot more medication and more intensive treatment. And it's pretty rare. I don't think we've seen anybody. We had one fellow who came in, was using in a pattern like this. And we put him on a benzodiazepine and we treated him. He didn't require those excessive doses like we had kind of anticipated. He did pretty well. But it is out there, kind of a strange drug. Benzodiazepine high doses. There's some research. Phenobarbital may work. Once again, not a lot of controlled studies. Everything's antidote. Gabapentin is adjunct treatment. In fact, they've used various anticonvulsants in adjunct to the benzodiazepine. Seem to be helpful. Oh, is that it?
Isn't that what River Phoenix died of, was the GHB?
Was it?
Intoxication?
I don't know.
Years ago?
I don't know.
It was. I think it was, yeah.
Yeah.
Yeah, that actor.
What form does that take? I'm not familiar with this. I remember to ask the question about.
Oh, I'm sorry. Wasn't that what River Phoenix took? I don't know. I don't know. They have various forms of it, and they got usually a tablet form. But like I said, there's been a lot of these drugstore or these backyard chemists and stuff that have done all kinds of various things, pressed it and said give it in a sheet form and stuff, but primarily it's a tablet form. And I don't even know right now. There may be some analogs out there that drug users are familiar with that nobody's caught up to yet. I haven't heard about it, but I know initially there were quite a few. In fact, some still being sold in stores, before it was caught up to it. So 6:30.
Any other questions?
What was the other question? Any other questions? Okay.
I
seen Ativan and Klonopin used sublingually for maybe a lower onset of it. Is that ever
Yeah, well, you know,
Why not?
any medication is probably going to be absorbed more rapidly if you take it sublingually, but there's no indication, there's no approval of using those medications because they're not sublingual form. You know, it's like the old kind of thinking, we used to use diphenhydramine under the tongue to try to bring the blood pressure down. You know, we open up a capsule and squirt it under the tongue and it worked a lot faster. So I would imagine that it does, but lorazepam and clonazepam neither will actually come in an FDA-approved sublingual form. Xanax does, I think now. It's actually a rapid dissolving form, you know, it's not necessarily sublingual, but yeah, I don't know. I don't know how, I don't think it'd be necessary, you know what I mean? If you really wanted to get somebody on board fast, then you use the only benzodiazepine that we can administer intramuscularly, because it's the only one that seems to work IM, and that's Ativan. Because it's got good absorption IM when all the other benzodiazepines don't.
They're using a lot of sublinguals and hospice, which is easy to take.
Yeah, yeah.
And the Subutex, sublingual, is it true that you shouldn't have anything to eat or drink for 10 or 15 minutes?
Some people, yeah, because the slow absorption, they say it will change the way the absorption is, the acid and so forth. But, oh, I forgot to repeat it. Sorry. I'm a bad boy. Okay. Hey, is it hot in here?
No.
All right.
On the neurotransmitters, there's just no telling how long before you get back to normal, right?
Yeah, it's pretty hard to measure because you know you can't document functional changes. And so you're dependent on subjective reports, and everybody seems to vary. You know what I mean? You know that always, even with the neurotransmitter theories and stuff, you can't really measure. Now, PET scans, you know, some of these new scanning techniques, we've actually been able to see some changes in the brain. When the brain's excited, we see it in a certain area. When it's downregulated, we see decreased activity in that area, like it's represented by, you know, heat or activity. So there's a lot of research on looking at functional way to measure those kind of things, but as it stands right now, we don't. So we're kind of all dependent on subjective. And nobody knows for sure. You know, even the kind of thing where we used to measure the metabolites. Really, it's such an inaccurate way to do that because some people metabolize differently. We actually don't even have good labs for measuring metabolites, you know, that are efficient. You know, they said with accuracy and so forth. So it's kind of it's all still hypotheses kind of thing. So it seems like the most protracted withdrawal syndromes you see are related to benzodiazepines. You know, and there probably is something going on there when you're a habitual user that taking longer for the brain to get back to normal. But I kind of described the idea that it's multifactorial, combination of things. Any other questions? That is a boring lecture, huh?